CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Welcome, everyone. I'd like to begin by acknowledging that I'm coming to you from the unceded traditional lands of the Syilx Nation in the Okanagan, and most of the people in this Zoom room are based in the unceded and ancestral lands of the Coast Salish people, the Musqueam, the Tsleil-Waututh, and the Squamish nations, and we are committed to proper stewardship of these ancestral lands. Today, we have an exciting lineup for our WIP. The speakers are Dr. Nick Bansback, Dr. Mark Harrison, and Dr. Rebecca Metcalfe. All of them are involved with CHÉOS. Nick and Mark are CHÉOS scientists, and Rebecca is a research associate there. Nick is also an associate professor in the School of Population and Public Health and director of the Masters of Health Administration program. Mark is an associate professor in the Faculty of Pharmaceutical Sciences, and Rebecca, who's just starting off, is a postdoctoral research fellow in the Faculty of Pharmaceutical Sciences. So without further ado, I welcome the three of you to present how to design clinical trials to increase enrollment and impact patient-oriented approaches to trial design. I hope you'll leave some time for question and answers at the end. Thank you.
Great, thank you, Aslam. Welcome, everyone. I'm Nick Bansback up here. I'm going to start us off and similarly just want to acknowledge the land. The team is predominantly being based at UBC in Vancouver, but the projects we're going to talk about today have listened to voices from across BC, actually across Canada, so acknowledge those lands as well. Just some disclosures and acknowledgements. Just particularly want to point out that whilst it's going to be three of us talking today, it was a large team, including a number of patients who have contributed to this work, and we'll make sure we try and acknowledge those properly at the end. So here's how we're going to play today. I'm going to give an introduction. I thought you didn't want to listen just to me, so that's why I invited Mark and Rebecca, who are going to talk about a couple of projects that I've been involved in around this theme of clinical trial design. So we're going to give two sort of separate sort of case studies, and then I'm going to come back and give a summary, and we're going to leave time for questions. But let me just set the scene. And I'm going to use a story of this. It's the Scott trial. We weren't involved in this trial, just to acknowledge it. It was a trial that was published a few years ago now, nearly 5 years ago, in New England Journal of Medicine. So like, you know, the top journal. It's a randomized control trial of stem cell transplantation in patients with severe scleroderma. Mark is going to explain a little bit more about this disease in a while. But the original design of this trial had 226 participants based on a sample size calculation of a 20% improvement in event-free survival at the 44-month time period. And they justified this sample size calculation with this statement that it's the minimum effect that is considered clinically meaningful for the acceptance of transplantation. Now, this isn't some new drug or something that we don't know much about. Actually, stem cell transplantation has been widely used for quite a few years in other contexts. So it's quite well known that it has severe potential side effects, including operative mortality. These were known. And so when you're thinking about whether this 20% improvement of event-free survival is worth the potential risks of the side effects, like these were things that patients who are trying to be recruited into this trial could work through. And in this case, it seemed that was not deemed a large enough improvement for patients. So actually, after struggling to recruit for a number of years, they actually changed the endpoints and reduced the sample size to 114 participants, which in the end impacts the usefulness of this study. We'll dig into sort of why a little bit more. But this story sets up two problems that we're going to try and address with some methods that we'll talk about today. And the first is actually the fact that the way we design clinical trials, actually, they're not done in a way that's actually very useful, just to be upfront. And so others have sort of written various reports suggesting that of the massive amount of money we spend on clinical research each year, a high proportion of it is actually wasted. It's not useful, is the terminology. And I think this quote at the bottom from Ioannidis is useful. They go into actually why much clinical research is not useful. But an important endpoint of this is that they fail to be useful, not because of the findings, but because of the design. Things that were known before the study even started. So let's just think that through for a moment. It's disentangling. This is not about trials who don't successfully meet their primary endpoint. These are trials that may well actually do that, such as the Scott trial, but actually, even when they meet their endpoints, they are actually of endpoints that are not necessarily important. The effect sizes are too small to be meaningful to the actual patients who might be wanting to use them. It doesn't include key information on other outcomes that are actually really important. And this little consideration between the sort of benefit harm and the ratio of those, and other factors around, or even the way that the intervention might be delivered. And others have also shown that if these are aspects of the trial design, then, and you're trying to get patients to enroll in this trial, then why are they going to bear a risk of potentially an intervention that they don't really want? And so this leads to sort of one of the many factors of low enrollment in clinical trials, which is pretty common when you're looking around. The second problem we'll talk about is actually composite endpoints. When they changed the sample size, they changed it from event-free survival in the Scott trial to probably the most complicated composite outcome I've ever seen. It included multiple outcomes in a way that is almost uninterpretable to even the clinicians who are meant to be using the results of this study. And I think this is the second problem. We're commonly seeing composite endpoints, and they can actually be really difficult to interpret. Let's just give this really simple example here of 3 outcomes, which might be all individually important to determining whether an intervention is working or not. And if you analyze them separately, then statistically there's some issues with that, because you're going to do 3 separate analyses, which potentially increases your type 1 error. So there's a rationale for combining them into one composite, where, like, just so we know, one outcome counts as an event. So whether it's a death, whether it's an event of severe high pressure, that all counts as an event. And it's mostly attractive because it increases the statistical efficiency in the power. So in the case of the Scott trial, it allowed them to reduce the sample size they required. And there are examples where actually it makes sense because it covers actually all the important components in the clinical course. But the issue with them is that these events are not all equally important. While a severe high blood pressure is an important event on its own, I don't think many of us would agree that it's as important as death, for example, or heart attack. But when a composite endpoint, an event is an event. They're all effectively equal. And so there's some problems that come out through this. And often these problems come because the events don't occur at the same rate. So it may be dominated by one of your outcomes, which might actually not be the most important one. So again, it leads to this issue about the usefulness of the results. And so I'm going ahead here, the issue of the results, but also then the impact and the interpretability of the results of that study. So we have worked on some studies, a number of them, we're going to talk about 2 today, which are under this sort of banner of patient-oriented research. So these are all things that have been identified by patients as important. So composite endpoints, actually patients saying to us, we don't really understand how we can use these. They engage patients as partners in our research, and they engage sort of relevant stakeholders. And then they're actually trying to think through how do we apply this knowledge into sort of healthcare systems, which is partly what we're trying to do with things like this today. And so both these studies were funded by the BC Support Unit. I was a cluster lead for one of the methods clusters. And so these actually came from both the health economics and simulation modeling methods cluster and the real world clinical trials methods cluster. So that's just a setup. I'm now going to hand over to Mark to talk to us about the first of these studies, and then he'll hand over to Rebecca and I'll come back at the end. So Mark, if you're there,
yeah,
I'm going to give you control. That should be good.
Okay, so thanks, Nick. So this is the first of the case studies, which is nested in scleroderma, and it was about, can we use patient input to better design randomized control trials? If this will advance for me. Okay, so Nick sort of hinted I was going to tell you about scleroderma. It's going to be a very brief introduction, but basically it's an autoimmune disease. So it's something that attacks the body, and it can affect almost any part of the body, as you can see that diagram on the right hand side. It is quite rare, but for people who have scleroderma, particularly severe scleroderma, it's potentially severe. And if you've got severe scleroderma, it can progress very, very quickly and lead to a very short life expectancy. In these severe people who are kind of the candidates for stem cell therapy, it could be quite an exciting option to have these new treatments available. Just to look at the treatment, again, this is very light on clinical knowledge, but basically what happens is that the patient has their own stem cells removed from their body. They then undergo a treatment, usually chemotherapy or maybe radiotherapy or a combination of both, where effectively their immune system is wiped out and reset. So that's kind of potentially dangerous in its own right in terms of having no immune system, and also the treatments that they get. And then they have their own stem cells reintroduced to the body in an attempt to reset the immune system without the autoimmune problems that have caused the scleroderma. So this was the trial that Nick talked about. This was looking at the stem cell therapy against cyclophosphamide, which is the typical comparison treatment. And as Nick was saying, it was designed for 226 participants. They were looking at event-free survival as the main outcome. But they struggled to hit those recruitment targets and made some changes which led them to try and reduce the sample size to 114 using this composite score. But they still struggled to recruit that, and ultimately they only recruited 75 people, which was about a third of their target, and that's going to be important later on. So they only recruited about a third of the people they intended to. So this was a case study that we came across, as I'll tell you in a second, with a conversation with patients and clinicians. But we wanted to understand whether there was something those trialists could have done in terms of changing modifiable factors that might have helped them increase their enrollment and impact of the trial. So just to tell you about the involvement of patients. So this was, we feel, a project that met the criteria of co-production. So it was sharing power from the point of generating the questions right through to the design of the analysis and the interpretation of those results. So as I say, this project was initiated with a conversation with a patient and a clinician who were trying to make sense of the results of that Scott trial that Nick showed briefly before. After we sort of came up with an idea around what we could do to try and understand whether there was something different in terms of the endpoints or the process of the trial, we actually wrote the funding application with the patient to the VC support unit who funded this. And then Tiasha came to be a team member from start to finish of this project. She pushed us to recruit other patients to the study to get a different perspective from hers. And that happened from the design stage onward. And Tiasha actually documented her experience of working with us as a team member in the patient. It's quite an interesting paper, I think. I've lost my aim slide, but ultimately the aim was to, again, just to understand those model factors. So we did this in 2 stages. So the first stage was trying to understand, first of all, what's going to be important to people when they're deciding whether to do something like a stem cell transplant. And we talked to patients using a technique called the nominal group technique. The key thinking behind this particular technique was that, first of all, it starts with a complete blank sheet. So we don't introduce any assumptions to patients about what might be important. And they generate ideas, they discuss them, and then ultimately they rank and prioritize these ideas, which is really useful for us because then we want to convert these 2 attributes for a discrete choice experiment. So once we know what's important and what rank they have and what kind of the most important factors, we can then move it along and try to understand what the relative importance of those factors are in making decisions. So briefly, the results from the nominal group technique told us, quite surprisingly, that the thing that was ranked most to patients was basically what kind of team was going to care for them. So they wanted much broader than a medical team, perhaps even introducing social workers and psychologists, which kind of reflect the severity or the seriousness of this decision they have to make. They then told us, I'm struggling with this one. They then told us about the importance of the finances and logistics. So this is quite a serious treatment. It requires a lot of planning and potentially a lot of time off work and time away from home. So there was a lot of financial and logistical issues to think about. And you can see in the middle, we're building up those attributes for the choice experiment. They then wanted to know about how good the knowledge and how good the evidence was around stem cell transplants in people like them. So it's important to have information about scleroderma patients. And they wanted to hear from physicians as well as people who've experienced the treatment themselves. So there's a combination of factors that would be interested in understanding whether this was a good option for themselves. So we've represented that as really as the experience of the people who are treating them. Then we get into the things that we're used to seeing. So the risks of treatment, which we've talked about, which can be either immediate or long-term. So those go into the choice experiment as an important thing. And then finally, they said ranked 5th out of all these things was the effectiveness and benefits. So what was it going to do for them? Was it a cure or a treatment? And this kind of reflects the thing that we normally think straight away as being the primary outcome of the trial. So those became all our potential attributes for the choice experiments. So once we have those, now we want to understand how people trade these off. So how do they balance all these factors when they're trying to make a decision? And how we do that is we try and get people to make choices based on these attributes and attribute levels, and see if we can predict what choices people might make given the things that they're seeing. That gives us some coefficients which really tell us the strength and direction of preferences. And then once we have those, we can use those coefficients really to try and build up existing real treatments and try and understand the value of those treatments relative to one another. And if we do that, we can then start to predict how a treatment might be adopted by people, or potentially how we might recruit people into a trial. So we do that just by building up the treatments and then dividing the value of treatments by the value of all potential options in a decision set. So let me show you how that works. So we've got these attributes that we developed from the qualitative work. So we've got 7 of those attributes. We then assign each attribute to have 3 to 4 levels, which kind of describe maybe the range of clinical benefits they could get, the types of risks and the likelihood of those risks, and then the different compositions of the care team, where the treatment's done, the expense to you, and so on. So we have different levels for each attribute. We then ask people to choose between 2 stem cell transplants, so stem cell transplant A or B, or legitimately they might choose to do no stem cell transplant for now. And then for each of those hypothetical choices that they're making now, we describe those using one of those levels that I showed you previously. And then we ask them to choose what they prefer. And based on those choices, we can then try to infer what's the most influential thing in that choice. And we ask people to do this a number of times. So in this case, we asked them to do them 12 times so we can start to get enough information about what drives an individual's choices. Okay, so we got quite a big sample for this this study. It was drawn from around the world, but primarily in the US and Canada. So our sample had a mean age of 7 years, primarily women, and primarily Caucasian. We had a mix of people of the types of scleroderma in our study. So we had some with diffuse, which is more like the type of scleroderma that would be eligible for a stem cell transplant, but also people with limited scleroderma as well. And a range by age of diagnosis, so mean age 43 years, and disease duration, again, we had a range of that, a mean of 12.3 years. So if we go back to our first part of this analysis, so first of all, what can we learn about predicting choices? So what are our coefficients showing about, which is the relative importance of these different attributes? So just to orientate you what we're going to look at, we're going to have all our 7 attributes with their different levels across the bottom. And then I'm going to show you attributes. And if we see a pale green upward arrow, we're going to look at those levels of increasingly having a positive impact on people's preferences. So you're more likely to do something. And then conversely, where we see pale red arrows going down, those are things that as the levels increase, they're going to have an increasingly negative impact. And these are ordered in magnitude of importance based on the trade-offs people will make. So what we found was that the years without further scleroderma damage, so that event-free survival, that was the most influential attribute. So that had the biggest positive impact on people's preferences. But if we looked at the risks, whether they're late complications or immediate complications, we could see that those risks are big enough or severe enough to offset the preference for the treatment, benefit, I should say. The next up was cost. So as cost increased up to from nothing to over $1,000, that kind of negatively affected preferences. Similarly, the further distance you had to travel, the less preferred a treatment would be. The increasing experience of a hematologist in treating people with scleroderma, so people like yourself, that had a positive impact on preferences. And then that composition of the team care, that had a small, arguably positive impact on preferences, but it was quite small in relation to everything else. So now if we use those coefficients, that bit of information to predict uptake, what we did here was we tried to replicate the original Scott trial design using the best available attributes that we had. So this is what we came down with there. Their study was evaluating a 5-year progression-free survival. And then we tried to plug in all the relevant coefficients that looked most like that trial. Once we did that, we tried to see if we could predict trial recruitment. And one of the things we found was that our base analysis for the Scott trial, based on the effectiveness that they expected to see, corresponded really, really closely. So we were able to predict an uptake of 34%, which corresponds with the 33% of the intended participants that they recruited. So it seems to be able to predict the effectiveness of the Scott trial. And then we plugged in different levels of effectiveness to see how a more effective treatment might affect recruitment. And even if we were offering twice as much benefit, it probably was only going to achieve about a 70% uptake at 10 years progression-free survival. So then the next stage was just to look at, could we make this trial a bit more patient-oriented? So we recognised that there were things that we've kind of paled out a little bit here that we perhaps don't have control over or couldn't change, but maybe we could add more members to the team in relation to people's preferences that they told us in the qualitative work. Maybe if we made it less burdensome to the people financially or close to their home, then maybe we might be able to help improve recruitment. And this is what we found. So compared to the original trial design, just by changing those 3 factors, those modifiable factors, it might be possible to get the uptake of the trial, which is essentially the same, but just modified to be a bit friendly to patients, up to 51%. And in terms of the clinical benefit, that's broadly equivalent to an extra 2.5 years of progression-free survival in terms of the increased uptake. So that was kind of a brief view of this study where we sought to challenge a number of assumptions, whether they're conscious or unconscious, that people make, including us as methodologists when we're thinking about what trials should look like or what research design should look like. We found that qualitative results suggest that the potential benefit, which we tend to be focused on, isn't always the most important thing, and things that we could change, those modifiable factors, could help improve the uptake of treatment. And the decision to undergo stem cell transplant, that's kind of multifactorial, and it will depend on some of the processes as well as the outcomes. So we think we could help people designing trials like this in a way that will improve the probability of recruitment just by incorporating patient preferences into that design. And with that, I'll hand you over to Rebecca for the next stage of this. So I have to give up remote control.
Great, thank you, Mark. And thank you, Nick, for that great introduction. Sorry, these are just sort of going forward on their own. I think we've got it under control now. I think that really sets the stage there. So how can we do a better job of making trials attractive to patients? But then once we've done our trial, how can we make our trials meaningful for patients and for decision makers? And that's what this work that I'm going to be presenting to you today is really about. And I was really lucky to work with an absolutely fabulous team of health economists and decision scientists, as well as patient partners to make this work happen. And the aim of this project was really to look at how can we integrate patient preferences into our trial, as I said, to try and make the trial results easier to understand and easier to use, because that's ultimately why we're doing these clinical trials, to help people who are making treatment decisions make the best treatment decision they can. And the solution that we're proposing here, as Nick described earlier, is to add weights to the analysis that reflect the importance of each component in our composite endpoint. So instead of treating all of our composite components as equal, when they often really sort of just on their face are not, allowing the weight to vary to actually reflect the importance that patients and clinicians assign to each of those outcomes. And this approach actually raises an additional question, which is whose weights are we using and whose outcomes are we using in these analyses? And I'm going to make the argument that we should be using patients' weights, and there are a couple of reasons for that. One is that patients prioritize different outcomes than clinicians and researchers, and they also apply different weights to different outcomes than clinicians and researchers. For example, there have been studies in cardiovascular health that have found that while clinicians might weigh death and stroke differently, patients sometimes will weigh those the same. And those are important differences that can change potentially how we might interpret our trial. We also know that patients are the ones who are most impacted by trial results because they're the ones who experience both the interventions and the outcomes. And allowing patients not only to sort of not allowing our analyses to vary, not only to reflect patient weights, but also to reflect the outcomes and interventions that patients value, means that our assessment might better reflect the factors that patients actually use to make decisions. So we have this idea, and then we wanted to apply it, and we did that using the control of hypertension in pregnancy study trial, or the CHÉOS trial. And the CHÉOS trial was a large, open, pragmatic, randomized control trial of about 1,000 individuals with pregnancy hypertension. And the trial was comparing two different treatment approaches. The first approach is tight control, which is an intervene now approach. So we're not going to let your blood pressure get very high. We're going to act now to make sure it doesn't get above sort of a normal or high normal level. The other approach is called less tight control, and that's more of a wait and see approach. Instead of intervening right away, we're going to allow your blood pressure maybe to get a little bit higher, but if it gets too high, then we'll step in and intervene. And in the CHÉOS trial, they had a primary composite outcome looking at infant death and a high level of neonatal care for 48 hours or more after delivery. And you can see that there might be a bit of a discrepancy here in the importance of each of these outcomes. And they also looked at a number of different secondary outcomes, and they found a difference here. So in the composite outcome, there was no significant difference, but in the secondary outcomes, they found two differences. So the first one was in severe high blood pressure, there was a statistically significant difference. And for the baby being born smaller than expected, there was a clinically significant but not statistically significant difference. So the results from this trial went on to inform clinical guidance really across the world, and current clinical guidance in Canada from the World Health Organization, from NICE, is recommending tight control of pregnancy hypertension, and also that care providers should consider patient preferences when they're recommending treatment to patients. But I'm just going to bring you back to this study, and let's look at the results here. So when we look at the composite outcome, no significant difference. And when we look at the secondary outcomes, what they found was that for severe high blood pressure, tight control was better, and that was a statistically significant difference. And when we looked at the risk of a baby being born smaller than expected, less tight control was better, and that was a clinically significant difference. So if I'm a patient or I'm a physician, I'm trying to figure out what do I do with this information, it can be quite challenging. So what did we do with this information? So what we wanted to do was really find out what are the outcomes and interventions that are important to patients, so that we know what are the factors that are influencing their decisions when they're facing this situation. The next thing we did was we conducted a preference elicitation survey, so a best worst scaling survey, to quantify the relative importance of each of those outcomes to patients. And then we took that information and integrated those survey results into our trial analysis using a patient-oriented composite. So a composite made up of patient-identified priorities, and then weighted that composite according to the value that patients assigned to each of those priorities. And I'll walk you through what we did for each of those because it's a lot for just one slide. So when we spoke to patients, we ultimately ended up hearing that there were 7 outcomes and interventions that they prioritized avoiding. And these are the 7 outcomes and priorities. So they wanted to avoid developing severe high blood pressure, preeclampsia, having their baby be born quite premature, having a baby born smaller than expected. A number of people wanted to avoid taking high blood pressure medication, needing a blood transfusion, or having a cesarean delivery. And just in terms of the context, how we came to these, we were looking at the different outcomes that were measured in the CHÉOS trial and asked patients what outcomes of all of these outcomes where there was a difference, any difference, not necessarily a statistically significant difference, any difference at all, which ones were important to you and which ones would be enough to change your decision about this treatment. So I think that's just important context in terms of the reason things like death or the infant needing a severe level, like a high level of neonatal care are not included in this list are not because they're not important. It's because they were almost identically, they occurred at almost identical rates in each of the treatment arms in the CHÉOS trial. So once we had those 7 outcomes, we used a best worst scaling survey, as I said, to identify the relative importance of each of those outcomes. And then we analyzed that using latent class analysis and identified 3 different groups of common preferences. So individuals in our study tended to sort of fall into one of these 3 groups. The largest group were folks who didn't have a clear priority. The second largest group were individuals who really wanted to avoid an early delivery. And the smallest group were individuals who prioritized minimizing medication. And this is just to show you the weights that the different groups applied. So in profile 1, those are the folks who had no clear priority. We can see that there's sort of an even weights assigned to each of these 7 different outcomes and interventions. Whereas when we look at profile 2, we can see that avoiding delivery before 34 weeks gets twice the weight as the next most important outcome, which was avoiding severe high blood pressure. And if we look to the smallest group, those who wanted to avoid taking medication, you can see that almost all, so more than half of the weight of this decision really relies on minimizing medication. And for some people who are maybe more visual, this is just another way to show that same information. So you can see that in the profile 1 group with no clear priority, all the bars are roughly the same size. In profile 2, that pink box is avoiding delivery before 34 weeks. And in profile 3, the green box is avoiding taking medication. So you can see this is quite a large, so it's a lot of weight for those folks on avoiding medication. So once we had our weights, we integrated those into the clinical trial, as I said, by designing a patient-oriented composite made up of those 7 outcomes and interventions and weighing them according to those relative weights that we got from our best worst scaling survey. And I'm just going to walk you through how we applied those weights to the patient data from the CHÉOS trial. So this is a hypothetical participant, and I'm only showing you 3 of the outcomes and interventions that we looked at just for simplicity, but we did look at all 7. And for each outcome we looked at, did the outcome occur, yes or no? If it occurred, we assigned a value of 1, and if it didn't, we assigned a value of 0. We then looked at how important is the outcome, and this is that weight that we identified before. And we simply multiplied through and then summed across to get what we're calling a weighted outcome score. And we did this for each participant in the trial, and then compared the mean score for each, we compared the mean score across trial arms. And we did this for each of the preference profiles, as well as for equal weights, which would be sort of the more traditional approach where you're treating each outcome or intervention equally. So what did we find? We found that when we used equal weights, similar to the CHÉOS trial, we didn't see any difference between less tight control or tight control. Likewise, when we use the weights for the no clear priority group, which were quite even, we see the same thing. No significant difference between the 2 treatment groups, between the 2 treatment arms. However, when we use the weights for the folks who wanted to avoid early delivery, we found that tight control was a better match for their preferences. And here, looking at these results, a lower score is better because that indicates that fewer highly weighted events occurred. So fewer of the events that people wanted to avoid the most occurred. In contrast, when we look at the people who wanted to avoid taking medication, less tight control was significantly better fit for their preferences. And then we wanted to do a threshold analysis, and we did this for preference profiles that didn't support the current clinical guidelines. So that was really the folks who wanted to minimize taking medication. And we did this to get an understanding of how much individuals' preferences would have to change in order to be in alignment with the treatment guidelines. And what we found is that for individuals who prioritized avoiding medication, less tight control was the better treatment or the more preference congruent treatment for them, as long as avoiding medication makes up 2/5 of the decision or more, which is sort of might be a little tricky to apply. But if you were thinking about it If avoiding medication is almost half of the decision, then less tight control is probably the better choice for a patient. But if it's not, then tight control may be the more preference congruent option. And what these results are really saying is that which treatment approach for any given person really depends on which outcomes they prioritize and to what degree, and that an individual's values can actually change which treatment a randomized controlled trial supports. So I'm just going to quickly talk about some of the strengths of the study. This was the first study in pregnancy to integrate some patient value weights into individual level trial data. As I mentioned, we used patient weights and patient-oriented composites, and this allowed us to include treatment requirements and not just outcomes. And we know that treatment requirements, and as Mark touched on quite elegantly, showing the effect that travel can have on patient recruitment, treatment requirements can really impact whether or not a treatment works for a patient. It addresses some of the issues raised with traditional composite endpoints, and this is a relatively simple statistical analysis which can accommodate covariates and is a robust parametric test. This does have some tricky implications for power, and we might lose some of that statistical efficiency that is gained by composite endpoints, as Nick raised. And this study was done post hoc, which might be a limitation as we weren't assessing the values of the women in the CHÉOS trial. But at the same time, that might make these results more generalizable as they represent the general population of women in Canada rather than the trial participants, and trial participants are often a bit different than people in the general population. And I think the message here is really that we need to stop treating composite endpoints and outcomes as if they're equal and as if the equal weights are value neutral. And future studies should consider how patient values can inform their analysis, either through the selection of outcomes, the weighting of outcomes, or both. I'm going to give it back to Nick.
Great. Thank you both, Mark and Rebecca. I've just got one slide and then we'll have some questions. So I think this is just an example of the area that we're interested in, this topic of decision science, how it can actually contribute to improving the way that we design and interpret clinical trials in the future. It's interesting, ICH has this new guidelines where they're really suggesting that patients should be more involved, engaged in clinical trial design. But there's no how do you do this? And I think, just to be clear, there's many other aspects, other researchers doing work in this area, like from how to design recruitment posters to consent forms, through to sort of other aspects of even designing the questions. So I do want to sort of acknowledge that we're just picking off two of many of the issues that are kind of going on here. But I think we're trying to sort of contribute some methods of actually how can you improve trials by actually engaging patients. And I think what we look at these approaches a little bit like is that they're akin to a sort of sample size calculation, something you do before you're designing your pivotal trial. And you could be done as part of your pilot study, actually giving you some information to satisfy both the reviewers, but also just to give you this kind of confidence that the trial, if you were to run it, how it would work, how it would have impact going forward. I think the last reflection is that both of our studies right now have been sort of retrospective. So we've taken studies that have already happened, look back. There's always that potential for sort of hindsight bias here of this is what you should have done. So I think we're now, having developed these methods, thought them through, we're really interested in actually using them prospectively. So there's people who are interested in designing clinical trials that they maybe are worried about having the impact from them, worried about enrollment, then we'd be really happy to hear from you and see if these methods might be appropriate for helping you out. So I'm just gonna sort of just put some of the names that have been involved in these studies. We're really grateful to them, and we'll leave you with our email addresses. Please feel free to contact us